7:33, so we'll get started. We'll walk a little bit slow so that others, when they join, they can also catch up with us. Good evening all to the weekly huddle. My name is Anup Agrawal. I'm an interventional cardiologist at Care Hospital, Hyderabad. I'm joined by my colleague and co-host for the session, Praneeth Pulamari. The huddle is an audience level interactive session where we discuss a variety of things mostly focused around healthcare. And what we do is we typically pick up a topic or a clinical case and we try to restrict our discussion around that. The basic premise of the huddle is to bring our casual hallway discussions to a more organized platform like this one and share our ideas, something that we would do in our OPD or in our wards or something. While we do want to talk about science, the huddle mostly aims to bring our practice patterns and understand the rationale of what makes us take a particular decision. And in doing so, we try not to come up with right or wrongs, but rather what makes us take a particular decision. This is our 29th session. We have been doing it for over 6 months now. And our topic for discussion today is ischemic nephropathy. Typically, what I do is I start with a clinical case and I initiate the discussion with Dr. Praneeth giving me his opinion, and then we open it for audience interaction. This is not a presentation, so if anybody has got any thoughts, they can unmute yourself and share your thoughts. Obviously, you should let the other person finish their thoughts before you speak for yourself. So with this introduction, I'm going to start today's session. And just to acknowledge a few of the new attendees or the first time attendees for today's session, we have Dr. Murli joining us. He is a senior radiologist, head of department for radiology at Care Hospital, Banjara Hills. And we also have a few nephrologists joining us. We have Dr. Shrikant, who used to work at Care Hospital. That's how I got to know him. He's currently working at AINU. We have Dr. Vikrant Reddy. He works at Care Banjara. And Dr. Rajiv, this is, I believe, your second session, sir, or maybe third. I missed it. So we're going to have some discussion on this front. So Praneeth, I have a clinical case and we'll just get started. There are some details about this case, so we'll try to go slow. I'll ask your opinion. And of course, because the topic is ischemic nephropathy, we are going to focus our discussion on that. So sure. This is a 58-year-old male. He's diabetic for about 8 years. He came to my OPD for a routine checkup. His diabetes is managed by his neighborhood doctor, and it has been reasonably controlled. He got diagnosed with hypertension 2 years back when he was 56 years of age. And since then, he's on 2 antihypertensive agents. Getting some crosstalk. Okay, since then he's on 2 antihypertensive agents, and his blood pressure at home mostly ranges around 140 systolic to high 80s diastolic. Dr. Prithvi, okay, thank you. So that was his background: diabetes for 8 years, hypertension for 2 years. He was diagnosed with CKD by his neighborhood physician as well. And that was last year, when his creatinine on continuous occasions have been ranging somewhere around 1.6 to 1.9. His last reported creatinine was 2 years ago. At that time, it was around 1.1 and 1.0, something around that. So he comes to my OPD. He's otherwise feeling fine. He just said, because I am hypertensive for about 2 years now, I should rather see a cardiologist for it. He used to smoke in his youth, but he doesn't smoke anymore. About 2 years ago, he got a health checkup done. At that time, his ECG echo TMT was normal. Somebody ordered a coronary calcium score at that time, and that came out to be 150. History and physical wise, he does not have any other signs and symptoms suggestive of peripheral neuropathy or retinopathy. He is on glimepiride and tenlicret for his diabetes. He's on amlodipine and carvedilol for his hypertension, and 20 milligrams of atorvastatin. He was never tried on ACE inhibitors or ARB due to his potassium typically ranging above 4.5, like 4.8, 4.9. So with the fear of hyperkalemia, He has never been tried on ACE inhibitors or ARB. I did get some evaluation done. I'm not going to give you all the details. Most of them were otherwise normal. The pertinent findings I will tell you. In the urine analysis, his protein to creatinine ratio was 0.1. The rest of the urine analysis was okay. His urine microalbumin was 25. So this guy comes to me, 58-year-old, diabetic for 8 years, hypertension 2 years. Blood pressure is slightly high. In the OPD, his blood pressure I got was about 144/90 with a heart rate of around 80. The rest of the examination was okay. So he comes in for a routine checkup. His blood pressure is borderline controlled. CKD for about a year or so with a creatinine of 1.6, 1.9 and a bland urinary sediment. Medications I told you about. Some coronary artery disease, but asymptomatic. He's on statin for that, not on aspirin. Praneeth, my question to you is, he's otherwise a very routine, I would say, for the lack of better word, a bland patient for us. What do you make out of it, particularly with regards to his hypertension, CKD, diabetes? Is there something that you can do to further assess what is going on with him? Your interpretation, Praneeth.
So yeah, good evening everyone. So hypertensive, diabetic, the numbers of hypertension are not so comfortable with the numbers. So I want to modify his drugs to get his blood pressure controlled more, because these subset are a higher risk for atherosclerotic cardiovascular diseases. So I want to target them more, and CKD itself probably leads to hypertension, difficult to control hypertension kind of a thing. You said you already evaluated for it. I would take my opinion of the in-house nephrologist to see what he looks into it, and look into it. So my focus predominantly as a cardiologist is to look at his heart, and those things seems to be okay. So I would refer or take opinion of my nephrologist, and then see what else need to be done.
Okay, all right. Praneeth, I'm just going to continue the discussion and then you can chip in whenever you need to. I'm muting you. So whenever we talk about ischemic nephropathy, I just want to highlight that there are 2-3 different things that we're talking about. Hypertensive nephropathy, that's a different subset. Patients can have hypertension, they can have nephropathy, and we'll discuss it with our nephrology colleagues a little bit here. That's a subset. But when we are talking about ischemic nephropathy, we are talking about basically more or less 2 things. One is renovascular hypertension. Essentially, you have renal artery stenosis, which is causing your blood pressure to go up via RAS mechanism. Or we have got ischemic nephropathy in the sense that your renal function is compromised because of ischemia. And this typically would happen only if you have bilateral disease where your kidneys are getting persistently hypoperfused and eventually ischemic, leading to your kidney dysfunction and all this. So when we're talking about ischemic nephropathy, these are 2 particular components that we are discussing. And just for the sake of discussion, because I know in about 40 minutes, we really cannot complete everything. The focus is mostly on ischemia-induced renal dysfunction rather than more of a renovascular hypertension, although we can talk about renovascular hypertension at times when we need. So this is essentially more related to ischemia causing kidney disease. So Shrikant sir, if I could just get your opinion on this. My particular question to you is, 58-year-old guy, diabetic for 8 years, hypertension at least diagnosed 2 years ago with borderline controlled blood pressure. Creatinine is elevated. Urine analysis to my eyes is not significant. What do you make out of it? Can we call it diabetic nephropathy? Can we call it hypertensive nephropathy? Or is there something else going on? Dr. Shrikant, if you could unmute yourself and share your thoughts.
Yeah, good evening, everybody. Can you hear me?
Yes, sir, we can hear you.
Yeah, like what you said, with all the background, only thing that is missing is a significant problem is the absence of proteinuria. With proteinuria in place, I would have considered diabetic nephropathy. One more important information that we ask when we see such a patient is the kidney size, whether they're normal in size or whether they're shrunken. Any information regarding that, Dr. Anu?
Yes, so I have not done ultrasound on him yet. And this is the point of discussion, that what kind of ultrasound and what kind of further, like how we should assess him further from that particular standpoint. So I haven't done that yet.
See, the point for discussion for today is ischemic nephropathy. Leaving that aside, in this patient, I would consider strongly diabetic nephropathy. The proteinuria is not significant. I would reconfirm it with a 24-hour urine protein, and most probably with retinopathy in place, I would label him as a diabetic. Now, ischemic nephropathy is a very, very tricky disease. Like what you said, the problem with diagnosing such a disease is that most of the times patients do have some amount of ischemia ongoing for a long time, but clinically they will be having multiple comorbidities like what you said, diabetes, hypertension. All of them will be masking this disease. So picking up this isolatedly is difficult. So most of the times you won't get an isolated ischemic nephropathy. It's diabetic nephropathy, hypertensive nephrosclerosis with superimposed ischemic component ongoing. So picking that separately out of this mixture becomes very tricky. I would only evaluate for ischemic nephropathy if there are any warning signs that I would consider, like patient is having recurrent pulmonary edema or creatinine is fluctuating too rapidly. That's one unusual thing that I'm sure most of us would have seen in practice, that one day creatinine is 3.3 and then a few days later you see that it's not really bad. That happens because small changes in volume status can cause a significant change in the renal function in these patients who have ischemic nephropathy. So frequent changes in creatinine, pulmonary edema, unexplained deterioration in renal function, and lastly the uncontrolled hypertension or the resistant hypertension kind of situation. Unless these situations are there, I wouldn't really evaluate. I don't know what happened in this patient, whether any angiogram was done or any Doppler was done, but honestly, I wouldn't proactively ask for a Doppler in every such patient that I see. I think Dr. Vikrant can add on to this if he can comment if I'm missing anything.
Perfect. Thank you so much, sir. Vikrant, sir, we would love to hear your thoughts. And I have a question on the top of it. So, Shrikant, sir, if I misspoke, this patient does not have retinopathy or neuropathy. So, Vikrant, sir, we will discuss about this. And one particular question I have, as you share your thoughts as well, the substrate for atherosclerotic vascular disease in the elderly, there is common substrate, same diabetes, same hypertension, same smoking, same all this, and they can themselves cause kidney disease, which is far more common. So how do we resolve this conundrum? And is ischemia something which is so down the line in our thought process and even clinical relevance that we really should not be thinking too much about it? Vikrant, sir, about this case, and then my question, if you could share your thoughts.
Yes, sir. Good evening, everyone. So, as there is no retinopathy and there is there is not much of a proteinuria, we have to think really whether it's really a diabetic. Are we dealing with a diabetic nephropathy or a non-diabetic renal disease like an ischemic nephropathy? So that's where we are in. So, next evaluation I would do is to ask for a renal size. Typically, in this case, we can ask for a renal Doppler study as a baseline investigation to understand how is the kidney size and reasonably understand what is the flow in the kidneys, and also the Doppler, our radiologist will give the peak systolic velocities across the renal arteries, so that it will give a reasonable understanding what is happening at the level of the renal arteries. So that will help us in this case to proceed further. So that's
Perfect.
the other thing is, as Dr. Srikanth rightly said, mentioned 4-5 points where unless and until we have a flash pulmonary edema or a fluctuating increase in the creatinine or a rise in the creatinine, or if you add an ACE inhibitors or ARBs, if the creatinine goes up very rapidly, or so these are the pointers more significantly towards atherosclerotic ischemic nephropathy. So that's where we suspect that this patient might have been having an ischemic nephropathy. But this index case, it is difficult because it's only in 8 years, not much of not very difficult to control hypertension, CKD is there, so bland urine, everything. So is difficult to say. This is maybe could be an ischemic nephropathy with an underlying diabetic nephropathy also could be a possibility. So then second question, what you were asking, Dr. Pranav? The second question, what was that?
Basically, the question was in line of the same thing.
It's in line with the same thing,
right?
yeah.
That you have so many risk factors, which,
Correct.
like let's say a diabetic patient who is also predisposed to atherosclerotic vascular disease comes in with CKD or renal dysfunction. How do we know how much is diabetic, how much of it is, or when should we start suspecting atherosclerosis other than pulmonary edema or creatinine fluctuation, which has been discussed previously?
Yes, sir. So most of the time, the atherosclerotic renal disease or the typically ischemic nephropathy is most often what we see is something like an incidental finding, which we see in patients who have a CKD. So suppose if we are working up for a diabetic nephropathy and we get a patient has an uncontrolled hypertension and we get a Doppler done, shows say 30 to 40% stenosis of the renal arteries, atherosclerotic. So then again, typically our understanding is that this may not be the cause for this may not be the cause for ischemic nephropathy, because unless and until the stenosis is significant, that is dynamic stenosis up to 70% stenosis is there, it's difficult to say that 30 to 40% will cause ischemic nephropathy. So typically we need to have a much higher stenosis to call them as ischemic nephropathy. That is what my understanding is. Cardiologists also should tell us that whether this understanding is right, or because we typically feel that 30 to 40%, if incidentally if we detect in a diabetic patient, we feel that it's not an ischemic nephropathy.
Perfect. Thank you so much, sir.
Yeah.
Can I add something to this?
Yes, Shrikant sir, please go ahead.
Yeah.
Dr. Rajiv, I'll get back to you. Dr. Rajiv will come to you in a second. Shrikant, please.
Yeah. So usually the cardiologists have a tendency to open up these blocked vessels. That's what the cardiologists always feel. But like what Dr. Somraj Garu used to say, it's like the simple organ like heart and brain, which have only one type of cells. Unlike that, the kidney has a huge number of different systems and is an ecosystem within itself. So the way in which it manages its blood flow to keep supply to the glomerulus to manage a good clearance of toxins and urine, as well as a good supply to its peritubular capillaries to keep the functioning and to keep a good flow to the parenchyma is very, very complex. So those are personally, I feel, reasons why you need not really worry too much about the vessels. And all the trials which have attempted to see whether opening up these vessels will transform into a better outcome with kidney or better outcome with respect to the overall picture of the patient have been unsuccessful for this reason, because the kidney has an ecosystem in itself which can manage this ischemia very well with the support of a few medications which will I think help in the working of this ecosystem more easily. That's my personal impression about this.
Thank you so much, Shrikant sir. I love when it all starts with cardiology. We love to do that. So Rajiv sir, I want your opinion on this case, and I also have one particular question for you. We did talk about renal size in this, and I think doing a renal ultrasound is not a bad option here. Do you think all these cases we should also be asking for a renal Doppler, or you think a simple ultrasound KUB is a good enough thing to start? And your comment about this case as well, Dr. Rajiv.
Yeah, so this case, 58-year-old man with a background history of smoking, who doesn't have retinopathy, who presents with, probably CKD stage 3B, and doesn't have any proteinuria. So although the concordance between retinopathy and diabetic nephropathy is not that great in type 2 diabetes, you would, I mean, this would still throw up some red flags for what we call as non-diabetic renal disease. So nowadays, if you see, I mean, we're all talking about ischemic nephropathy, but I would prefer to talk about a more umbrella term like maybe atherosclerotic nephropathy, because that includes ischemic nephropathy, atherosclerotic renovascular disease, hypertensive nephrosclerosis, all these things. And they do share some similar features towards the end as they converge clinically in the time course. Ischemic nephropathy, I would think of more when there is resistant hypertension, when the creatinine is rising too rapidly, as Dr. Srikanth was saying. Whereas atherosclerotic renovascular disease, when somebody has persistent depressed GFR, the proteinuria is only mild, and if the ultrasound or the Doppler is showing features of high resistive indices, that is a situation in which I would think of this particular term. Coming to this case, this patient is only on 2 drugs, and this patient is not on the drug which is good for hypertension in the presence of diabetes. The reason being given is that he has borderline hyperkalemia. I would think of something like a type 4 RTA in that situation. I would evaluate the hyperkalemia. I would put him on a ACE inhibitor or an ARB, along with maybe some sodium bicarbonate to take care of the hyperkalemia. I would not be evaluating this patient further unless he showed an instability in his GFR or his hypertension became difficult to control. If he has stable CKD and his ultrasound is otherwise looking okay, I would not be investigating this case further. That would be my approach.
Perfect. Thank you so much, Dr. Rajiv. Let me get some 1 or 2 cardiologists in the board, and then we'll go to Dr. Murli for the imaging aspect. Dr. Pabba, if you could hear me, Dr. Kailas Pabba, if you could hear me, I have a particular question for you. Sir, you have been practicing cardiology for quite some time. A 58-year-old guy comes with a new onset hypertension, something that he got diagnosed with at the age of 52. As a cardiologist, does that give you a red flag? Why is this patient having a hypertension at the age of 56? Or you think it is too common of a phenomena that we should not be paying too much attention to? Dr. Pabba, your opinion on this, please. Sir.
Hello?
Yes, sir. Please go ahead. We can hear you. Yes, sir.
At this age, essential hypertension is more common, no?
Yes, it is. It is absolutely more common. It is absolutely more common. But should we be paying attention, or should we be giving these patients some chance and give us red flag before we jump onto something else? That's my question to you.
No, it depends on the BP levels. If they are very high, we have to give importance to this renal.
Okay. Okay. And sir, what do you do in these kind of cases? The case that we are discussing, I hope you got the clinical case that we discussed. Do you go beyond your traditional therapy, or do you actively look for renal artery stenosis in these cases who do not have any so-called red flags for uncontrolled hypertension or fluctuating GFR or pulmonary edema or those kind of things?
In this patient, there is no pulmonary edema. We can go with traditional treatment.
Perfect. Perfect. Thank you so much, sir. Thank you so much for your opinion.
Most welcome.
I'm going to mute you. Thank you so much, sir. We have Dr. Somaraju with us. Somaraju, sir, if I could just get your opinion about these kind of patients, should we be more aggressive than what we currently are? And we currently are not very aggressive looking at ischemic nephropathy for the reasons mentioned, that A, diagnosing or dissecting it out is very difficult in the mix of diabetes, hypertension, age, and whatnot. And secondly, the therapy which we have, which is essentially interventional therapy, has never been conclusively proven to change the outcome. So effectively, our approach towards ischemic nephropathy is already at a very back stage. Do you think we should be a little bit more aggressive than what we currently are in diagnosing or addressing ischemic nephropathy? Dr. Somaraju, sir, if you could, yeah, sir.
Thanks for asking me. leave me at this time and ask our other colleagues. I will talk later.
Sure, sir. Absolutely, sir. Anybody has any other thoughts before I ask Dr. Murli about the radiology aspect? If anybody has any other clinical thoughts, they can please share with me or share with us. Let me just quickly brief about the few things that has been discussed. So whenever we talk about, yeah, Rajiv sir, you are unmuted. Do you have something to add?
Yeah, so because this patient has been a diabetic for 8 years, there are some tricky ways in which diabetes can present. One of the things is that nowadays we are more aware of this entity called non-proteinuric diabetic nephropathy, which is something that this case might well fit into. That's one thing. The other thing is that let's say that we are dealing with a case of renovascular disease here. One of the very interesting things is, let's say you have two kidneys and one of them is stenotic. The stenotic kidney is protected from diabetic nephropathy because the pressure is not transmitted to the stenotic kidney. So there are all these tricky ways in which diabetes and diabetic nephropathy can present in what would otherwise be throwing up red flags for non-diabetic renal disease. But having said that, I would not change my approach in this case. My approach would still be to put him on an ACE inhibitor, manage his hyperkalemia, and take care of his CKD.
Thank you so much, Rajiv sir. So I just want to, okay, Srinivas sir, do you have something to add? Dr.
Yeah, I have a for the nephrologist. A patient who's going for CABG.
Anup, can you hear me?
Yes, sir, we can hear you.
I don't agree that this patient with this hyperkalemia and non-proteinuric issue, ACE inhibitors, ARBs have no role and don't much help. We should consider diltiazem or verapamil as a first choice in such a patient. And in the absence of proteinuria, ACE inhibitor ARBs and in a patient with hyperkalemia should not be thought of as a first choice.
Thank you so much, sir. Srinivas sir, please go ahead.
Yeah, for a patient who has an incidental significant renal artery stenosis, blood pressure is well controlled, and he has a creatinine of say 2, and if he's going for a CABG, what is the opening of the renal arteries before going for a CABG?
Okay, so sir, before anybody answers this question, I think this answer to this question, cardiologists should be giving this to nephrologists, not the other way around. So we will discuss about this in a second. Dr. Murli sir, I'm going to come to you. I just want to share for 2 minutes my thoughts. So one thing that was brought was the degree of stenosis. So let's make it very clear. Renal arteries, you need very high grade of stenosis for it to either manifest as renovascular hypertension or ischemic nephropathy. We are talking about 90%, 80%, those kind of stenosis. We are not even talking about 70, 75% stenosis. We are talking about 90% stenosis, 95% stenosis, occluded arteries. We are talking about that degree of stenosis because we know that you can have an occluded renal artery and still a functioning kidney. That is because, as Shrikant sir was saying, that miraculously works because also for the fact that they get a lot of collaterals from other arteries, which we don't check very often. And I don't know if it's a good way to check as well. So when we talk about renal ischemia, either manifesting as hypertension or manifesting as nephropathy, the degree of stenosis has to be quite significant. So we are talking about the degree. Also, we are talking about the velocities. Now, while we say that velocities of more than 100 centimeters or 120 centimeters per second is pretty high velocity, suggestive of renal artery stenosis, the point of intervention we are talking about is 300, 350, 380. We're talking about that level of stenosis. So a 4 meters per second velocity in renal artery is probably worth paying attention. 1 or 2 meters per second, while they signify renal artery stenosis, there is no meaningful clinical outcome that is going to come out of this, no matter which angle we look at it. A lot of trials which came negative, remember, this is such a heterogeneous population that we talked about with diabetes, hypertension, age, smoking, all these things, that when we start enrolling these patients, every person who fits into certain criteria starts getting enrolled. So we really cannot pinpoint or cannot super select which patient we are going to enroll, because then these trials will never be completed. So we are talking, if you take Coral trial, Astral trial, and if you go to their designing, every 3 months their protocol changes just because they just cannot get the patient data set. But the very common essence of interventional therapy does not work are few. Number one, we are either intervening on arteries which are not critically stenosed. Number two, we are intervening in the kidney, which is already to the point of damage that even if you open the artery, nothing happens. Or number three, we still don't know how ischemia affects. There is all these metabolic theories, inflammatory theories, something like we also have in cardiac, where we think that the kidney damage, which starts with ischemia, but probably leads to an inflammatory phase or like a free radical phase or whatnot, where now resolving ischemia may not necessarily improve the kidney outcome. So a lot of these theories are in place. I can assure you none of these can be tested in the trials in a randomized manner, because selecting these patients is extremely difficult. Even the multinational trials, they struggle doing that. And every 3 months, they keep modifying their protocols so that they get some patient or whatnot. So I'm just giving you a background of the reason why I chose this topic is because everything about ischemic nephropathy is so complicated that like I think ischemic cardiac disease is complicated, but ischemic nephropathy is complicated to the degree that I cannot even imagine. And that is why a lot of times we don't have clear answers and we end up discussing this. So that was my rant and justification on why I chose this particular topic. Murli sir, I want to bring you in here. All my renal ultrasounds, I write there requesting Dr. Murli to do. Sir, ultrasound KUB versus renal artery Doppler. If you could just give us a little bit of idea, and I have some very particular questions about the tests. Resistive index, if you could tell us a little bit about it. Second, what is this corticomedullary disease? What is this medical renal disease that we write grade 1, grade 2, grade 3? Number 3, how frequently do you see renal size mismatch in your routine ultrasound, and what do you do about it? And number 4, is there a reflex renal artery Doppler that we should be doing whenever you are doing a routine ultrasound based upon certain findings? Like if there is a renal asymmetry or if there is something else, are there certain reflex which would tell you that I should also do Doppler in this? Murli sir, I asked you 4 or 5 questions. If you could just give us a brief idea about this diagnostic. Murli sir.
Good evening. Medical renal disease are depending on the ecotexture of the kidney. We have 4 to 5 grade. That grade we generally compare with the right side, we compare with the liver, and left side we compare with the spleen. And with obliteration of the corticomedullary differentiation. If there is obliteration of corticomedullary differentiation, that grade goes to 4. Right. Then in grade 1, there is just increase in ecotexture, but it is less than the liver. Right. In grade 2, it is more than the liver, but you still can make the corticomedullary differentiation. In grade 3, it is almost equal to liver, or you cannot make the corticomedullary differentiation is hazy. More than that, in grade 4. Right. This is depending on the ecotexture of the kidney compared to the liver and spleen. Your next question is asymmetry of the size. Yes, sometimes there are cases where there is asymmetry of the renal artery. We take anything different less than 80 millimeters, that 8 centimeter in length, as lower limit of normal. If it is borderline, it is okay, depending on the size of the habitus of the patient. Whenever there is asymmetry in the size, you should advise for renal artery Doppler if the patient has got hypertension. What was the other question?
Resistive index.
Yeah, the normal resistive index is below 7. Anywhere above 7 points towards medical renal disease. Not only RI, in the main renal artery, you have intrarenal branches. And only you don't take RI into consideration along with the Doppler, intrarenal Doppler waveform, whether they have systolic and how the systolic and diastolic flow is. We also take into consideration. Anywhere above 7 is abnormal, RI. Anywhere below 5 is considered to be due to vascular cause, renal artery stenosis. Anywhere above 7.7 is generally we take it as medical renal disease.
And so just to clarify, that 7 and 8 is that 0.7 and 0.8, right?
Yes, yes.
Yeah. And sir, what are these renal velocities that we report? If you could just give us an idea of how we check, and do we compare it with aortic velocity? How do we do it?
See, basically, ultrasound is operator dependent. In good hands, experienced hands, the renal artery, there are certain criteria to diagnose renal artery stenosis. Increase in the peak systolic velocity. Generally, we take as a 120 centimeter per second. Any stenosis which is more than 50 will have a velocity of more than 180 centimeter per second. Then this is one criteria. Then another main criteria, sometimes the velocity may increase due to certain condition, thinking or a different reason. We have to take renal to aortic artery ratio. It should be more than 3. If the renal to aortic ratio is more than 3, it is definite that the stenosis is more than 50%. Right? This is another criteria. Then another third criteria is turbulent flow. If there is a stenosis, post-stenotic dilatation or turbulent flow will be there. This is the third criteria. Then sometimes you visualize the renal artery, but you don't see the color flow within it. That is another criteria. If all these 4 criteria are taken into consideration, I think the sensitivity will be more than 98%.
And sir, do we report this resistive index or whatnot in our routine ultrasound, or we report it only when
we do report when we do a Doppler.
Doppler, okay.
Yes.
So only when we order Doppler, then you report this.
Yes, yes.
In a routine ultrasound.
Routinely, I have an habit of seeing renal artery for routine patients. If I can see without much problem, I do take Doppler signal from the main renal artery, and if the resistive index is below 7, I don't mention it. If it is more, I do mention it.
And sir, in your opinion, what is the overall prevalence of renal size mismatch of all the ultrasounds that you do? Is it 1%, 2%, 5%, 10%? In your opinion, of all the ultrasounds you do, how frequently?
Between the right and left,
yes.
more than 5 centimeter. Sorry, more than 2 centimeter. We take it as a criteria of disproportionate size. I hardly 3 to 4%.
3 to 4%.
Yeah, on routine ultrasound.
Sir, anything you want to tell us about ordering ultrasound or ordering renal Doppler, something that we always make a mistake of ordering? Is there something you would tell physicians on something we should change our pattern?
Yeah. See, this is a good question. I receive renal Doppler in patients who are in ICU who are not able to hold breath. In patients who are breathlessness, obese. See, the renal artery, depends on the patient habitus also, patient preparation also. You tend to see a good renal artery, the whole of the renal course in a thin, well-built patient. You cannot advise a renal Doppler in a patient who is not well preserved, who is not able to hold breath, who is very obese. And it is operator dependent. And you need time to do it, minimum half an hour for a renal Doppler, which is precious time.
Perfect. And sir, one last question I have. This is something I just got off the internet. I have no idea what this is. Do you know what is bold MRI? B-O-L-D. I've never heard of this term. I just got off the internet. Do you know what is bold MRI?
Yeah, even I'm not very. This is a new sequence where in 1.5 Tesla, you have renal. They see the it is not specifically for renal artery. Right. I don't have much knowledge about this sequence.
Okay. Perfect.
Yeah, Anu.
Yes, sir.
Yeah, this Dr. Vikrant.
Yes, sir.
Bold MRI is
Sir, your voice we are losing. It became very faint.
okay. So is it okay now?
Yes, much better.
Yeah. So the bold MRI is nothing but blood oxygen level dependent MRI, where basically typically you do, as Murli sir said, on a 1.5 Tesla machine. Basically, it demonstrates any cortical hypoxia is there. So if you have the level of oxygen maintained in the cortex of the kidney, so it typically demonstrates the level of hypoxia. So if the level of hypoxia is more and your kidney size is okay, you have a more advanced renovascular disease. So you can as well stent this kidney. So it almost bold MRI corresponds to a 70 to 80% stenosis of the renal artery. So you can as well stent this kidney. That's where it helps us whether stenting helps or not.
Have you ever had a patient who had a bold MRI report with them? Do you know of any center which does it?
No, I have not seen. Yeah, not seen. Yeah.
Okay. All right. Perfect. So my agenda of discussion is mostly done. I wanted some opinion from nephrologists, cardiologists, and the opinion for Dr. Somaraju is reserved for the last. Anybody who has got any thoughts, they can please unmute yourself. I'm going to ask Dr. Chandramukhi. Ma'am, if you could unmute yourself and just share your thought. I have one particular question for you, the same thing which I asked Dr. Somaraju. Ischemic nephropathy eludes us. We don't know how to diagnose. We don't know how to manage. Nothing is very clear about it. And I believe correctly so, we don't have that much of clinical, we don't think about it that much. Do you think we should be a little bit more aggressive about diagnosing ischemic nephropathy? Are we going to make any difference? Dr. Chandramukhi.
Good evening, all. It's true, Anup, that I also don't have much experience and truly speaking, much knowledge about this ischemic cardiomyopathy. Ischemic renal disease. So like only we are seeing the patients with like hypertensive renal disease or CKD patients who are having other problems and acute renal injury. So truly speaking, I don't have much knowledge to share about this. And truly speaking, we should be thinking more about this and we should have some knowledge about this. Thank you.
Thank you so much, ma'am. I just want to highlight also that in the space of ischemic nephropathy, there are certain low ballers. Low ballers are some of which has already been mentioned. Person coming to you with flash pulmonary edema and hypertensive crisis. Put on inhibitors or ARB and their creatinine jumps to more than 50% or 70%. These are low ballers. These are easy. These are our MCQ questions. We all got that questions right. If I see one such patient in a year, I feel very happy about it, and I keep telling my colleagues for the next 3 months that I saw a patient like that. But those are too few and far in between. But whether we should be going beyond that is what we are trying to discuss. Again, I'm inviting if anybody has any thoughts, they can unmute yourself and share their thoughts. Srinivas sir, let me also answer your question, and then you can revert back to that and you can share your thought. So the question that you asked is unilateral renal artery stenosis, hypertension, patient going for CABG. Let us try to identify this or unpack this a little bit. Unilateral renal artery stenosis, and by the way, whenever we are talking about renal artery stenosis, we are talking about significant blockage, not 50%, not 60%. We are talking about 80-90% blockage. So renal artery stenosis, if it is unilateral, it should not cause ischemic damage to the kidney. It can only cause uncontrolled hypertension. And whenever we are talking about uncontrolled hypertension and renovascular as the cause of it, there is enough data that has told us that if you can manage these persons' blood pressure medically, then intervention is no superior to that. Intervention can work only if you cannot manage this patient blood pressure medically. So if you have a unilateral renal artery stenosis, then renal dysfunction is not the concern. The concern is hypertension. If hypertension is controlled, then we don't need to do anything. If hypertension is uncontrolled with everything that you could do to the best to the patient, then these patients should get interventional therapy, provided their stenosis is a high degree. And if this patient is going for CABG with an uncontrolled blood pressure, I would think it would be better off if you fix that stenosis before the patient goes for CABG. So that was my answer to the question, and we can opine on that as well. Srinivas sir, did that answer your question and your thoughts that you wanted to share?
Yeah, my question was slightly different. I'm a patient having a significant stenosis, but he has a reason for a revascularization, which I was thinking is during the CABG, if the pressures fall down, due to the presence of a critical renal artery stenosis, would it compromise the renal function? In that case, should we open the renal arteries before sending the patient for CABG? That was the question which I had.
Okay, so transient fall in blood pressure with renal artery stenosis causing renal damage, that is something I don't know. I don't think it will cause problem, but I truly don't know that answer. If anybody has got insight on that, they can share it with me. Vikrant sir.
Yeah, yes, sir. So the thing is, Dr. Srinivas Raju's question was very practical, basically. So most of the time we see cardiovascular disease, CKD, very common, and patients with diabetic kidney disease, they will have both atherosclerotic vessels everywhere, be it heart and be it kidney. So sometimes we see such situation. I had some experience like this in the past also, where the patient is going for CABG, he has atherosclerotic vascular disease, and also has a significant renal artery stenosis. Say at the time of angiogram, if the renal angio was done and it showed a stenosis of say 80%, so we advise them to go for a stenting first, because if this patient suffers a low blood pressure during the surgery or in the post-op period, and this patient is going to have a renal shutdown. So before going for CABG, if he goes for renal artery stenting, so then we could save him from any renal shutdown in the intra-op or the post-op period. That's what is my experience, that we should go, and we have done it in the past also at care, that we stented them and then we allowed them to go for bypass surgery.
It's interesting because I have never encountered such situation in terms of somebody coming to me asking that, hey, can you stent this artery because this patient is going for surgery? New thing for me, and I will watch for it. This is very interesting. Very, very interesting. Shrikant sir.
Can I comment here?
Yes, Shrikant sir, please go ahead.
I'm not in completely agreement with this kind of a scenario, because the kidney, just like I told, is an ecosystem within itself. It can manage not only ischemia, it can also manage a significant short-term loss of blood supply with reasonably good efficacy. Only thing is, there can be ATN, definitely. There can be a dialysis requiring renal failure, but all such ATNs tend to recover off. So they tend to, I mean, the kidney function tends to, it's not like brain or a heart that it is dead forever and you can't do anything about it. So my personal impression is you can as well wait. If see, it's not a common occurrence that all the CABG patients land up in a shock or land up in a complete hypotension during the surgeries. It may occur, may not occur. That is a risk which we take during the surgeries. I think with that risk, with an understanding that the patient may have a dialysis requiring AKI also, it is not mandatory to this. The only thing is we should stop AS inhibition if he is on before any major surgery, because that can further compromise the GFR and push them into a faster dialysis requiring state. So I would definitely stop ASARBs, but stenting just for the sake of a surgery, I'm also not in agreement with it, with due respect to opinion of others. Thank you.
Because this was really interesting to me. As I said that as an interventionalist, nobody has come to me to say that stent for this particular reason, but intuitively, while it has arguments on both the sides, this is certainly something that I should think about. I do have a question for anybody in the audience, and I don't know the answer to that. If anybody has any insight, they can. So patient who has got, we talked about this 40-50% renal artery stenosis, which really we should not do anything about in terms of intervention or whatnot, because they don't cause any problem. Similarly, you have 40-50% stenosis in the coronary arteries. We don't do anything about it, but then we follow them, we monitor them, onset of symptoms, or later on some new ECG findings, or later on some stress test positivity or whatnot. My question open to discussion is, anybody who got diagnosed with a 40-50% renal artery stenosis, which is by no definition or stretch of imagination is causing any problem, should we do some kind of follow-up to these patients, like every year, every 2 years, every 5 years? I don't know. And if we do want to do a follow-up, what kind of follow-up we can do? Unfortunately, we don't have a ECG for kidneys, and ischemic nephropathy typically has got a bland urine sediment. So anybody can share their thoughts about, should we follow these patients? Is it worth following every 2 years, 5 years? God knows what all. Anybody has got any thoughts on that? So I will just share with you 2 literature anecdotes, and this is one of the things I was reading a few weeks ago that got me interested in ischemic nephropathy. 2 things which I read. One is, if you follow all patients with renal stenosis, renal artery stenosis, in about 3 years, 40% of them will progress to significant renal artery stenosis. Not clinically significant, that is not the point. The point here is not 40% will develop clinical significance. 40% will have progression of disease. Whether that means anything or not, we don't know. Second thing also I came across is up to 25 to 30% of patients in the dialysis unit first time when they come in, they have some component of ischemic renal disease as one of the multifactorial etiology of end-stage renal disease. Again, how to comprehend that, how to use it in the clinical practice, I still don't know. Whether us being very aggressive about it will actually make any difference, that also I don't know. So those are some of the unknown questions. If anybody has got any thoughts on this, they can share, and then I'm going to invite Dr. Somaraju for his thoughts on the case that we are discussing. One more thing I do want to add, that is just my extra thought process. Whenever we have patients whom we are thinking of CKD or AKI or whatnot, while I restricted my clinical presentation to basic hypertension, diabetes, and all this, anybody, cardiologist, physicians, or nephrologist, I'm sure, we all should be going through a checklist of all the causes which could cause kidney disease, like RTA that somebody mentioned, or drug use, analgesic, all these things, things that which are commoner that certainly we should be looking before labeling anybody or exploring for ischemic disease or whatnot. So that is just one thing I do want to highlight for the completion's sake, so that we don't get too carried away. Dr. Rajiv, your thoughts for what I'm talking.
Yeah, so regarding how one would follow up a case, with 40 to 50% stenosis, I'm not sure there is any evidence to guide us on that. But the way I would look at it in my OPD is, I would basically treat them like any other case of CKD. Follow them up every 3 to 6 months, depending upon their creatinine. But I would ask them to be very careful about episodes of volume loss. Treatment of, I would ask them to stop smoking, all these other measures. But if for example, if this person was having more than 0.5 grams of protein in the urine and I had put him on a ACE inhibitor or an ARB, then if that person had an episode of volume loss like gastroenteritis, I would ask him to stop the ACE inhibitor or ARB temporarily. So these are the things I would do, but primarily I would look at the way the creatinine is responding over the next 3 to 6 months. If the creatinine is rising up very rapidly, then I would see if the lesion had worsened for whatever reason. And with regard to what the clinical implications of a critical lesion is, from my understanding, the presence of a critical lesion of a single renal artery, it is associated, around 12% of these patients will go on to have end-stage renal disease. So, although a critical lesion is very, very important, not all of them end up in end-stage renal disease. They do end up in CKD in a huge number of cases, but in a lot of situations, we are able to manage them medically. I think, which is why you have all these ambiguous trials saying that there's not much difference between medical and interventional management of these cases. That's what I would say.
Perfect. Thank you so much, sir. Dr. Somaraju, if I could get your opinion about everything that we discussed, and what is your take on it?
Before I make any comments more on this, I just wanted to answer something related to what Dr. Srinivasaraju asked. So it's very important to realize that whether your patient for bypass surgery is going off pump or on pump, things are different. That will make a difference. Then the lesions are less than 70%. You don't particularly try to intervene. That's one issue. You leave it at that. And if it is more than that, it is a high-grade stenosis, then you decide on many other factors, including off pump or on pump. And then I also want to just add that the problem of diagnostic labels in medicine, as our knowledge of things increase, there are few areas in nephrology that have undergone more dramatic shift in competing treatment options and say concept changes as occlusive renal disease. Our understanding and our way of treating significantly change from time to time. Just like myocardial infarction is not a single disease, ischemic nephropathy is not a single disease. It's multiple diseases. And each patient is different. Considering all that, I would say that the decisions we make, I won't go into all those details, I'm just telling you, the decisions we make when a patient has what you think is significant renal artery stenosis, more than one of us should be involved. Have another cardiologist, and we have to have a multidisciplinary team of nephrologists, interventional radiologists, or radiologists, and everybody sitting together and making a decision rather than rushing with one cardiologist to make a decision. In my own experience as cardiologist, I practiced preventive tertiary cardiology, where a patient came with some borderline renal artery narrowing, and somebody advised stenting. And I practiced preventive nephrology by telling them not to go do anything about it. And unless somebody has any specific questions, I leave it at this.
Thank you so much, sir. Yeah, cardiologists are not a very good preventive nephrologist because our contrast really doesn't help kidneys. And certainly when we are doing or we are contemplating angioplasty, we should weigh in the amount of damage that we are going to do with contrast versus the amount of benefit that a person is going to get, which is up in the air, which really we don't have a good answer to. Somaraju sir, I have a very specific question to you. You have experienced more than what I have studied in my entire life, or truly speaking, my age. Sir, in your entire life, how many your patients got renal artery intervention? I must say, I wanted to ask evaluation, but that might be too big of a number. Intervention, if you give a rough number.
See, I must say, significant number went through, but that only when the stenosis is critical and hypertension was recent onset increase in hypertension, and then difficult to control hypertension, etc. But when a patient already has the renal dysfunction, the outcomes and the improvements in renal function or stabilization of renal function or deterioration is unpredictable. And this is more so with bilateral renal stenosis than unilateral renal stenosis.
Thank you so much, sir. I'll just give you one insight to the audience on the interventional aspect of it. If you are doing the intervention or if you are asking somebody to do the intervention, one has to really understand how much kidney is left there for us to treat. So what Murli sir was saying, if your resistive index is more than 0.7 or 0.8, truly speaking, if it is 0.8, 0.85, something like that, no matter how tight the stenosis is, the chances of any meaningful renal recovery, angioplasty, that is very, very low. Sir, Somaraju sir, I have one more question. Can a significant renal artery stenosis in a dialysis dependent patient cause renovascular hypertension? A person whose kidneys are all done, all damaged, but they have critical narrowing of both the renal arteries. Can it cause renovascular hypertension?
So, yes, when the kidneys are significantly damaged, hypertension may not occur in some percentage of patients. But renovascular hypertension may still occur if it is there was a recent progression and some say kidney function is left. And there are a small percentage of patients where they went on dialysis with renovascular problem, and they could come out of dialysis once the renal arteries are taken care of. There's a small percentage.
Thank you so much, sir. This is one question in the chat box. This is the last question we are going to take, and then we'll call it because of lack of time. Sir, the question is for Murli sir. What is the sensitivity of renal artery Doppler in picking up RAS, atherosclerosis versus fibromuscular dysplasia? Murli sir, can you tell us, when you do the Doppler, can you tell the difference between atherosclerosis versus FMD?
The fibromuscular dysplasia on Doppler, it is very difficult to diagnose. It needs, I think, CT or conventional angio. Atherosclerosis, yes, I can say 80% chances of picking up. And in case of fibromuscular dysplasia, I don't think, maybe in hardly 10% I can say. Less than that.
And sir, in literature, we always read how MRA time of flight is so good, no contrast, nothing. But every time when we order, we get this frowning eyes from the radiologist saying the images are not going to be good because of flow.
No. Time of flight is no. So MRI is flow dependent. As what we do for most of the renal patient, it's flow dependent. So you get a very good aorta signal from the aorta, but in case of renal artery, it doesn't give. It's always underestimates or overestimates the stenosis. I agree. If it is a 3D phase contrast, then sensitivity is more than 96%. If you give contrast, but without contrast, just phase contrast without IV gadolinium, I don't think the sensitivity is very high. Okay.
All right. We are 8:37, so I will close it here. Murli sir, I'm muting you. This is the last 2 minutes where we ask our first-time attendees about the thought process. Shrikant sir, you attended this huddle for the first time. It's a different kind of model that we started about 6 months ago. If you could just give us some comments about this model of discussion and how we can improve it. Dr. Shrikant.
Yeah, it is very good. Actually, it's like a learning from a lot of seniors, and it's without much of hassle of the video, PowerPoints, and other things. It looks like a casual discussion. Anyway, thank Anup for asking me to participate in the program. Thank you.
Vikrant sir, your comments on the session, particularly how we can improve it.
Yeah, Dr. Anup, it's a very good idea. I have attended a couple of sessions on this forum. So it's a very good idea because it's like a more of an open discussion. There's no hindrance, thought process, thoughts flow on. So more of like you're open to the discussion basically. So much more learning, practical learning is happening. I'm very happy to participate and thankful to you.
Thank you, sir. Murli sir, you are asking me what literature you need to read and what PowerPoints you need to present. What do you think of this? Was it a good model for discussion, and how we can improve it?
Yeah, it is a very good model. I'm not used to attending all these seminars and all, but this is something new. We don't have to really prepare ourselves. It is good. It's like a classroom discussion.
Rajiv sir?
Yeah, Dr. Anup, so what finally happened with your case?
So this case I just saw a few days ago. So I have ordered renal artery Doppler for this patient. I have ordered an ultrasound QUB plus a renal artery Doppler because what I in the last 6 months have been a little bit more aggressive in looking for ischemic nephropathy. I have still not been aggressive in intervening. In the last 3 years in care, I have intervened to 3 renal arteries so far. So the intervention we know is still sketchy, but I'm trying to look into the arteries a little bit more carefully. What I will do with that, I don't know. But now I'm ordering more of ordering more of ultrasound KUB plus renal artery Doppler in all these patients. So let's see what that report comes around.
Okay.
Rajiv sir, your thoughts on the session? Format, not the content.
Yeah, it's an excellent session. I actually like the relaxed format, wherein we can just discuss as if we are around a round table. I'll attend more of these because I'm enjoying this and I'm learning a lot.
Dr. Pabba, you are attending this session for the first time. You have vast experience treating patients, and I'm sure you have participated a lot in these kind of sessions. What is your thought process about this? How we can improve it, this particular session model? Dr. Pabba. Sir, you will have to unmute yourself.
Hello?
Yes, sir. Yes, sir. We can hear you.
Thank you, sir. Thank you so much. For the first time, I'm attending to this type of meeting, but it is very good, excellent, thought sharing, and informative. Thank you very much.
Thank you, sir. Praneeth, your closing comment. It was more of a theoretical discussion this time, but what do you think, and what is your take-home point for this?
Yeah, definitely one of the interesting topics which is worth discussing. Many loose ends, if I have to say, but learning or hearing the nephrologist perspective and the radiologist perspective of this particular entity is definitely thought-provoking. And yes, we keep looking into it, probably keep discussing, and we'll be knowing about this entity more. But definitely a good discussion and a nice topic to discuss about this thing. I enjoyed this session.
Thank you, Praneeth, and thank you all for attending today's session. My special thanks to the guests who are joining today, and to the attendees who are joining for the first time. We would really like your constructive criticism. So please email me or text me whatever we can do to improve. If you found this session worthwhile, maybe request you to share it with your colleagues. More people will join and more thought sharing will come. And the weekly huddle is hosted every Wednesday, and the link that you click today to join, the ID and the password, they are all the same for future sessions as well. So even if for some reason I don't send you the invite for next week, you can just use the same link and you will be connected next Wednesday at 7:30 as well. All the sessions are recorded and I upload them on podcast and on YouTube. I'm running behind on uploading to YouTube, but they're all there on podcast. You can simply search the Weekly Huddle on podcast or YouTube and you will get that same. If you want any recording in particular, just shoot me an email and I'll be able to share with you the recording as well. I thank you again for your time participating in this discussion. Good night, and I will see you all next week. Thank you so much for all of you attending. Good night.